Thank you, George. It's a pleasure to be here. It seems ironic that Jazz and I should have traveled all the way to New York to debate one another. We sort of debate each other every day in the lab. Let's look at the pathology. You've seen plenty of it today in a lot of the trials. I mean, calcium is really an imbalance between promoters and inhibitors of calcium. A lot of the drug therapy we've seen for LP(a) and things like that this morning. How about if we had something that blocked calcium and make our lives a lot simpler when we did get to intervention? We've got two forms of coronary calcium. They can occur together. They can be intimal, sort of spotty mineral deposition associated with atherosclerosis and predictors of future events. We have a medial component as well. It occurs along the external elastic lamina. We refer to that often as deep calcium, seen in chronic kidney disease, diabetes, advanced age, et cetera. And of course, there's a link between all of that. This should be self-evident. Anytime you've got calcium up there, whether you're measuring it by OCT or IVUS, just seeing it angiographically, the outcomes are much poorer. Most of the trials that have been lumped together here were not done with that kind of advanced imaging, but they're just done with angiography. And there's no question that these come out poorly, so we've defined that it's a problem, it's continuing to get worse, and our outcomes are affected by this. Image guided assessment, here are just some of the angiographic things you can see on the left before the injection. I think it was made obvious today in the cases. As Samin said, that basically take cine at first, then inject, look for that calcium, you can see it. In all three of these examples, there are forms of mild, moderate, and severe calcification. Many times we can't cross these, so it's hard to evaluate those with imaging. If you can go ahead and score it. The IVUS and the OCT scores are listed here side by side. But once you get up to, and I'm not sure why this thing keeps shutting off. Okay. Once you get up to 3 or greater, we think that the stent expansion is going to be adversely affected. So those scores are nice if you can cross, but many times we're forced to just look at it and say, hey, it's a real tight lesion, it can't cross, I see it angiographically, it's in orthogonal projections, I probably have significantly calcium. How do we deal with it? NC balloons, Wolverine, cutting balloons, angioscope, specialty balloons, but mostly what we're dealing with is atherectomy, rotoblator, Diamondback CSI, shockwave, et cetera, and laser. You can see, looking at all of them, they can handle eccentric, concentric, superficial for the most part. Deep is a little bit of a question. Nodular, we've had multiple discussions today about that. The longer the lesion, the better you want to sort of move towards atherectomy, particularly rotoblator if it's very high-grade calcified disease, as I've mentioned several times. Using CTO techniques becomes very important. These are things in which we can potentially use these devices. Comparing them side by side, you know how they work: differential cutting, differential sanding, photoablation with a laser, and lithotripsy, which can handle superficial and deep calcium. Very simple to use, and therefore its utilization has become rather dramatic. They're compatible with most guide catheters, and the clinical indications you're well aware of. Combination therapy, you've seen that as well today, whether it's atherectomy and balloon, atherectomy and modifying balloon, laser atherectomy, NC balloons, IVL can be added to any of the above. Despite the cost, it may be beneficial to do this in combination to improve the overall outcomes and stent expansion. So the key comes down to this particular algorithm. And although it looks daunting, the top left is really measuring the calcium the way we've described it. Going down it, it's a matter of can I cross or can I not cross? If we can meet this intravascular imaging, we know to use atherectomies, specialty balloons, lithotripsy. But if we can't cross, we can't use any of those balloons. We have to move over to the atherectomy panel on the bottom left. So let's do some cases. Here's somebody with a mid-LED CTO, unambiguous proximal cap, reasonable distal landing zone, Gaia 3, Corsair Pro XS, getting across fairly simple, looks pretty straightforward. When we look at the IVUS, we can see that there is some calcification, and the really question is, we want to modify this somehow. Can I get the balloon across or can I not? Well, the fact that I got the IVUS catheter through is a pretty good indicator that I can probably get IVL through, maybe with a little backup support from a guide extender. So I've met the criteria for modification. I've looked at the possibility of getting across with that balloon as based on what I've just described. And I can go ahead and do this with an NC balloon. I can do with IVL. In this case, a Wolverine was used. We end up with a final angiographic result that looks like this. And all goes well. So pretty simple to use that algorithm. How about in this particular case? Now I've got a densely calcified mid-right coronary lesion, class 3 angina, inferior ischemia despite optimal medical therapy. In this particular case, we couldn't cross with anything. We could not cross with a balloon. So we were able to get a microcatheter crossed, use atherectomy with a rotablator, managed to get into that situation, and then go ahead. You can see what it looks like on the post-rota atherectomy on the right. At this point, OCT was performed in the subtotal RCA. You get a good feel for both the diameters and the presence of calcium there. And as a result of that, shockwave was used on top of this in conjunction as part of the multi-device type approach that we use to try to expand this 4-millimeter lesion as far as vessel as much as possible. On the subtotal RCA, there you can see what it looked like, and this is what it is in the final. So in this particular case, the algorithm is very easy to use. Can't cross with anything. You got to use atherectomy. So where is atherectomy mandatory? I think we're going to come to the same conclusion just based on what we've said. How about this particular case? Did this one last year, severe distal left main disease leading into a currently ungrafted OM1, but you can see that there's a closed graft distally. Nothing crosses. Got to use a 125 rotablator. Get yourself an initial channel that looks favorable. From this point, I can balloon up, stent, get a nice result like this. It's very easy. It's not rocket science. It's not like all the very dense biochemistry we heard this morning. I sort of feel like Neanderthal talking about calcium and chipping away at rocks. 67-year-old, CABG 2021. Everything closes except the lima to the LED, so obviously not a great surgery. Continued symptoms prompting a CTO of the right coronary. Here's a contralateral injection, and the occlusion occurs pretty close to the origin. So this is a very tough case. Here's some different orthogonal view of this. We've got some collaterals coming to the left. Not great septals, though, so a retrograde approach does not look that favorable, but neither does an antegrade approach. Very difficult. Use a 6-gram judo wire, pushing the guide out. I don't have the ability to get anything in there to give me some support, but I was able to get that wire to go in a little bit, and then eventually was able to pass it further and further into the vessel. Looks like we're on target, and then finally gets down distally. So it looks like I'm done. Pretty easy case. Wrong. Nothing else goes down here. No balloons, no backup, no support, no dilatation proximally. So what can I do here? 1 and 1.25 millimeter balloons. Tried, don't advance. Tried to inflate a little bit. They all rupture, and nothing's going on. Well, the only thing I can use in this particular situation over this particular wire would be a laser. So here's a laser. It's 70-70, pulse of 50-50 contrast injection. That's going to work, right? Nothing. Won't go down. I don't really have any choices here. I said retrograde's not great. What do? Got to go back and use more laser. So went to 38 laser trains, a new indoor record. Somebody asked, why did you stop at 38? I said, because the laser broke. So now I'm really stuck. But eventually it did modify and fracture the plaque there. Remember, laser doesn't really ablate calcium very well, but it will fracture it under these conditions. Fractured it enough to get a microcatheter down. That allows me to get a wire down and use a rotablator. No balloon would go down there, but a rota did. And this is where I, unlike what we've seen, I go very readily to a faster speed, 180,000 RPM, sometimes even 200,000 RPM if I'm having trouble getting through there. Particularly if the ST segments are going up, I've got to get through quicker and establish antegrade flow. So that's what was done. Skip through another hour's worth of work, and you're doing ballooning, IVL, and get a good result on opening up this vessel. So trends in atherectomy, despite the fact that it's been around for 25 years now, going up, a result of the complexity of the disease, both orbital and rotational atherectomy. But we see that IVL, of course, going up dramatically. So modification with these devices is accelerating as the patients get older and calcium becomes more prevalent. They're living past their initial infarcts. They're developing disease. They've been bypassed 15, 20 years ago. That's all calcified disease when they come back and you're trying to reconstitute the native vessel. So all of that goes up, and all the combinations of the above, as we've seen, also go up. So the SCNI consensus algorithm goes back to the same branch points that we've talked about before. Do you have enough calcium to warrant this? Can you get a balloon across, or can you not? This determines atherectomy. This determines when you can just go with IVL. So the conclusions are, respect calcium. When I get a case referred in, I'm not only looking at which vessels are involved, where they're involved, the tortuosity, I'm looking for calcium, because that's the primary component of acute and long-term MACE. Prevalence is increasing with age, obesity, and diabetes. All the preparatory tools have the ability to facilitate delivery expansion and lower complication rates, but we don't know if you can always deliver them. It's better to modify first before stent deployment, because afterwards your options are diminished dramatically. The use of atherectomy is growing, not diminished with the advent of IVL. In fact, the two combination strategies are very, very effective. Calcified nodules, less than 180 degrees, we've had a lot of discussion. They will also work with these strategies as well. So my conclusion is atherectomy a must? I look at the common sense observations. Obviously, not for all calcification, but you should be respectful of calcium. You should look for it and try to identify where you're going to have problems with it. You can't shockwave what you can't cross. If IVUS does not cross, neither will the shockwave balloon, so you're back to using something else to help deliver the device. And if balloon can't cross or expand, then yes, atherectomy is a must. Thank you very much.
Terrific.